A
Visible?
very good morning to everyone. I apologize that I am not able to attend the live session of the AIOS 2021 conference, but I hope you're enjoying this virtual program. And today, my topic is evaluating binocular myopia. So, why is binocular vision important in myopes? When we measure myopia or the achievement or the improvement in myopia, we always measure the distance vision. Is it 6.9 or 6.6? And our Snellen visual acuity becomes our visual function. And that is what we all as ophthalmologists measure. What we forget is the functional vision. Now, what is functional vision? That is near work and whatever a child does. And today, there is definitely an epidemic of myopia, but there is also an epidemic of near work and near work symptoms. Now, binocular vision disorders have shown that they are associated with near work symptoms and are associated with reduced academic achievements. And therefore, we should be concentrating not just on the visual function of myopes, but also the functional vision of myopes. The International Myopia Institute recommends that we do these 5 tests for each myopia child. That is accommodative lag or lead, amplitude of accommodation, distance and near phorias, heterophorias, near fixation disparity, and AC by A ratio. Why is binocular vision important in myopes? First, binocular vision can help us identify pre-myopes. In the impending myopia epidemic, we need to find out children who are at risk of developing myopia. Pre-myopes have a higher accommodative lag. The association becomes stronger after onset of myopia. Children with a high AC by A ratio have a 20 times higher risk of developing myopia. In these children, there's a recommendation for outdoor sunlight time of 10 to 14 hours per week, progressive lenses, as well as vision therapy, and this may prevent them from becoming myopes. Binocular vision can help identify children who will respond to progressive addition. A child with normal binocular vision, progressive addition spectacles may not show much of a myopia control, but in the presence of esophoria and accommodative lag, can show treatment effects to progressive lenses. Third, binocular vision is altered in contact lens wearers. Children with low accommodative amplitude have a 56% better myopia control response to orthokeratology wear compared to normal accommodators. Ortho-K reduces the accommodative lag and esophoria in myopes compared to single vision contact lenses. Multifocal contact lenses affect accommodation response as well, and may have a role in myopia control. Binocular vision can influence our prescriptions. High minus spectacles provide a base in prism at near, moving the image further away. When these children move to contact lenses, they show an exophoric shift as they lose the base in spectacle correction and may start having intermittent exotropia. Esophoria, however, may benefit from multifocal and ortho-K lenses, and progressive lenses are better than bifocals. Accommodative lag may be improved with ortho-K lenses. And finally, binocular vision can change due to atropine therapy. Atropine causes a dose-dependent reduction in amplitude of accommodation and a tendency towards esophoria. In these children, a reduction in concentration of atropine, alternate day therapy of atropine, and progressive or bifocal lenses are recommended. Now that we have seen what are the advantages of measuring binocular vision in children of myopia, let us do a quick recap of the basics of how to measure these. Accommodative lag. In this, you will use a handheld retinoscopy, and the retinoscopy is done at a near distance of 33 or 40 centimeters. There is no need for any distance correction. Flippers over both eyes help so that both eyes are accommodating at the same time. Near refraction is measured and there is no distance correction required. Fusional reserve vergences. Use an interesting near target. First, use base in prisms to measure the divergence fusional reserve, which is generally 12 prism diopters, and check for diplopia or diverging eyes. Follow it up by base out prisms to measure convergence fusional reserve, which is generally 25 prism diopters. After this, repeat the divergence reserve again to measure accommodative fatigue. Phoreas. Now, phoreas is something we as pediatric ophthalmologists and strabismus, we measure this very often. So fixating target and do a cover test and a cover uncover test. But what is important is that we do it with the spectacles as well as with contact lenses. Next is amplitude of accommodation, which is measured by 100 divided by the near point of accommodation, measured in centimeters using an RAF rule. While using the RAF rule, we can use the push away method, which is better for small children who are unable to identify blurring very easily, or the pull up method for a little older children. The AC by A ratio can be measured by the heterophoria method or by the gradient method. In the heterophoria method, the measurement is done by interpupillary distance in centimeters plus n minus d divided by A. N minus d is in diopters. AC by A ratio by gradient method can be measured in two ways. If you're measuring at near, which is 33 centimeters, use convex lenses. And if you're measuring at distance, which is at 6 meters, use concave lenses. And here the method is L minus O by D, where L is deviation with the lens in diopters and O is deviation without the lenses in diopters, and D is the power of lenses used in diopters. All of this is done binocularly and using the full correction, that is their full myopic correction. The take-home messages for my topic today is that be aware of your patient's binocular vision function at 3 times: before glasses prescription, at every new change of glasses, and at every new treatment modality. That is when you start atropine, or when you shift to contact lenses, or after surgery for heterotropias. Thank you for your patient hearing, and I hope you have a wonderful session ahead.